with us today. I can see Ranita there. Hi, Ranita.
Hello, everyone.
Do you want to tell us where you're joining from?
From India, Northeast, Manipur.
Manipur. And do we have, thanks, Ranita, and do we have any more people from the Northeast with us today? Not yet. Or Rita, does that count? Do you count as the Northeast or are you North? In Patna. Are you North? We can't hear you, sorry, you're on mute.
Odette,
Yes, also, you're on mute. You're in the North or Northeast? Sorry, Anil, what were you saying?
Oh no, that's okay.
Oh, good. Okay. Actually, I'm getting quite a lot of echo. Are you getting that too? Not quite sure what's happening there. Oh, it's gone now. Good. So did we have any observers with us today, Davinia? Did that ever happen? Do you know?
No, unfortunately, I don't think so. So I think we are on our own.
Okay, that's all right. I just thought I'd ask the group to introduce themselves if they were joining. And I just am standing in for John Haverick today, one of our team members. John was going to facilitate the group tonight or this afternoon for you, but he is unable to join us because he had a family bereavement. So I'd really like to acknowledge his work in preparing for today's session, and I'm sorry that he can't be facilitating tonight. I just also want to thank Pallium. Often we run out of time at the end of the sessions, and I just want to say thank you to Pallium for all your hard work in setting up these sessions, coordinating all the inquiries and managing the new registrations. I know this is different to the usual discrete ECHO Pallium courses, and we have new people registering all the time. So we're really grateful that you are so expert at what you do and keeping on top of it all and making it possible for more people to join as we go along. Now, today's session intends to be directed towards and sort of and brought to us, if you like, by the nursing and allied health members of ECHO Hamrahi. And our presenters today are from those fields. So I thank Dr. Vidya and her team in Vizag for preparing their case presentation, and Sarah Begley, Joan Ryan and Rachel Coughlin, all APLI exec members who have prepared the Australian case presentation and the topic presentation. And it will be interesting, I think, to reflect on some of the similarities and differences between these two presentations. So the overview for today is a 10-15 minute presentation by Rachel Coughlin, who is a senior palliative care physiotherapist amongst her other many roles. She can tell us perhaps more about what her other interests are, if you like, Rachel. And then we have a case presentation from the Vizag team presented by Priyanshu, Dr. Priyanshu, who is a physiotherapist in that team. And then a case presentation from the Australian team presented by Sarah, Joan and Rachel. And then we will break out into discussion groups. And I think you've received the slide with the case and questions for discussion. Then we'll have time to come back, feedback, and have a general group discussion after that. So we've got a busy program, but I think it'll hopefully, and I'd really encourage you to really have some great discussion together. So with that, over to you, Rachel, for the topic presentation on falls and frailty. Thank you.
Thanks very much, Odette. Can you hear me okay?
Great, yeah.
Awesome. We're having some fairly large power outages in our area at the moment, which tends to happen every night, somewhere between 8:30 and midnight. So fingers crossed I'm okay until I'm okay for the next hour and a half. So as Odette said, I am a palliative care physiotherapist. I'm based in Melbourne. And I spend my time between doing that and doing a PhD looking at palliative care in humanitarian emergencies and crises. So I actually did a little bit of work with the Save the Children team during the Kerala flood some years ago. And I'm particularly looking now at palliative care in conflict settings, which is very topical over the last couple of weeks. So I'm just going to share my screen, I think. Can you see that all right?
Yep.
Yes.
Beautiful. Excellent. Technology working, internet working, so far so good. So just going to give a really brief overview on frailty and falls and what that means for us as palliative care practitioners and in the palliative care setting. There's been a huge growth in literature on frailty as a topic over the last 10 years or so, particularly looking at frailty in older people, but also a little bit on frailty in palliative and end-of-life care. What's come out of that literature is that there's no one widely agreed definition on what frailty is, and there's not one accepted scale or assessment score to determine frailty. But we do know that it's a concept that is different from aging. It's different from disability, and it's a concept that is often overlooked in healthcare settings, particularly in acute hospital settings, which then has really significant impacts on our ability to assess a patient, to know what interventions are best, and to really plan according to a patient's goals and wishes. So whilst there's not one agreed definition, an overall definition is that frailty is progressive. It's a progressive decline, often involving multiple systems, multiple organ systems, and it's shown by a loss of function, a loss of reserve, so a feeling of being tired and fatigued and weak, and ultimately increased vulnerability to disease and death. Patients who present with things like falls, describing that they feel like they've got off legs, or they just feel a general sense of tiredness and weakness, or who present with delirium are frequently those who are living with frailty. Frail people are more vulnerable to adverse health outcomes, and with greater vulnerability, something that might seem reasonably small for us, like a urinary tract infection, can cause significant morbidity, and it can lead to things like delirium, falls, reduced mobility, incontinence, and ultimately leading to hospitalisation, sometimes institutionalisation and death. And frailty can also have a significant personal impact, including care dependence, loneliness, and social withdrawal. Frailty is more common in older adults and common in patients living with multiple comorbidities or life-limiting illness. But it can occur independently of these things as well, and so it differs from the normal aging process. And transitions into hospital and hospital deaths are much more common for people who are living with frailty. So this graph shows that frailty is a dynamic process. So over time, whilst the severity of frailty can fluctuate, it usually describes a period of progressive decline or a kind of prolonged dwindling that might happen over several months or even years, with periods of acute illness and sometimes smaller periods of recovery or rehabilitation, but transition to levels of worse frailty is more common than any kind of improvement. And as I said, although definitions vary, it's generally suggested that having one or more of these frailty syndromes, things like falls, delirium and dementia, having multiple medications or polypharmacy, incontinence, being immobile and needing end-of-life care, should really prompt us to do a holistic assessment of the frail person and prompt a referral to palliative care. There's a strong relationship between frailty and an increased risk of falling. So over half of adults who might be assessed as being frail are reported to have fallen sometime in the last year. And we know that frailty-induced falls, people with frailty are at greater risk of fractures and soft tissue injuries, often hip or wrist fractures, and greater risk of hospitalisation and institutionalisation, such as to aged care. And as the severity of frailty increases, the risk of future falls will increase. In Australia, for example, there's been a lot of research done on falls, and we know that falls are the leading cause of hospitalisation in people over 65 years. Women tend to fall more than men, and women experience higher rates of injury than men. And falls can happen in the home, in the hospital setting, in the hospice setting, and in aged care facilities. And falls are often highly underestimated, particularly in aged care settings. So we need to understand why people fall, what was the cause of the fall and what was happening at the time, if we're going to try and minimise the risk of future falls. So risk factors include intrinsic risk factors, which are things like a history of previous falls. If you've fallen more than once in the past 6 months, you're more likely to fall again. Medical history of chronic illnesses, medications, and certain medications can increase risk of falling, and things like sarcopenia, which is the degeneration of muscle mass associated with both the aging process and common with cachexia in late stage cancer patients. And many of these intrinsic risk factors will be accelerated in our palliative care patients. And then under extrinsic risk factors, you have things in the external environment which are often amenable to modification. And Sarah will talk a bit about that later in our case study, but it's often things that physiotherapists, occupational therapists and nurses are good at assessing and providing advice on how to modify. And then you have behavioural risk factors, things like limited physical activity, poor nutrition, and inappropriate choices around footwear and clothing. And our frail patients often become weaker, both due to disease progression, but also because they start to limit their physical activity and they become deconditioned, or they may have bed rest, so they're even further deconditioned. They may be being introduced to new medications, they may have multiple comorbidities, and they may have metabolic changes towards the end of life, leading to confusion and delirium. And so as a multidisciplinary care team, we play a really important role, I think, in identifying these risk factors and then coming up with ways together as a team to modify them. As well as the clearer impacts of falling, like fractures and head injury, there's a lot of hidden costs, consequences of falling as well. And some of these create a bit of a vicious cycle for a frail person. So a person who falls may have an increased fear of falling for the future and a reduced confidence. They may then limit their activities and their social interaction, and in turn, the restriction of activities can further impede their physical capacity and further exacerbate the risk of falls. So it becomes a really vicious cycle. And as well as all of the individual costs of falling, falls also result in a massive financial burden on health systems as a whole. So falls are devastating to society and to individual people for many reasons, but they're not something that we always take seriously enough. And I think in some hospital settings, certainly here, there's often a lot of falls fatigue. On our palliative care ward, we have signs in every room which say falls prevention is everybody's business. And I think it's hopefully become clear in our discussions around the case studies that we all on a palliative care team have a role to play in falls prevention. The severity of frailty can be used to predict end of life. So patients with severe frailty will have a higher risk of death within the next 6 months. And even a mild frailty is associated with a 50% 5-year mortality rate. So recognising severe frailty is really an important part of identifying risk of death. And severe frailty shows us that advanced care planning or considering the wishes of patients regarding their care really should begin if it hasn't begun already. And then finally, as well as frailty being a useful prognostic indicator for death, people with frailty have physical, psychosocial and support needs that are amenable to palliative care and everything that we know and do. And so it's really important for us to understand who is frail and what their main goals and wishes might be. And although frailty is a leading cause of death in older people, it may not always be considered for palliative care or at the end of life. Often a clinical response to an acute deterioration, whether that be a fall or delirium or one of those other frailty syndromes, for a frail person might be a very protocol or pathway driven response that could be potentially invasive, sometimes distressing, without taking the pause to reflect on the goals and the choices of the frail person and their family. Later recognition of frailty can potentially lead to inappropriate and sometimes unwanted life-saving interventions, to acute hospital admissions, and to undertreatment of palliative care symptoms and concerns. And so early referral to palliative care in patients who are identified as living with frailty and who may have a high falls risk is appropriate and really important. And obviously over time, thinking of the dynamic process of frailty and that graph, there will be a naturally increasing emphasis on palliative care as a person's frailty advances. So that is a whirlwind tour of frailty and falls, and just to get us started on some of the important considerations for us working in palliative care. Back to you, Odette.
Thank you very much, Rachel. That was a great introduction and overview to the topic, and a really good way to start the discussion. So I'll open it up for questions or comments, or if anyone would like to ask Rachel for some clarification about any of her talk, please pop your hand up or sing out. We can't always see everybody on the screen, so if I don't see your hand up, just speak up as well. And remember, this session is really, we're hoping that our nursing and allied health colleagues will take ownership of this session and talk up. Who's that? Dr. Sangeeta, welcome. Did you want to ask a question?
In our previous, I want to ask something. In our previous trainings, we were taught about that Fried phenotype assessment scaling. So how many types of assessment tools are there by which we can assess the frailty? Which is the standard one?
I might throw that to some of my other colleagues as well to please, add your input. So I mean, in our palliative care ward, and I'll go through this when we go through the Australian case study, we use a falls risk assessment tool that's pretty commonly used, I think, across both palliative care and other inpatient hospital settings here, that helps identify all of those key frailty syndromes, really. As a physiotherapist, I don't use any other specific frailty scales, but some of our other colleagues may, so I'll throw it to you.
Can I say something more? Like we were taught about Fried phenotype, and which said like there are 5 domains, namely one is unintentional weight loss when it is there, then self-reported exhaustions, reduced gait speed, activity, and reduced grip strength. And when there are presence of 3 or more than 3 domains, then they said that there is presence of frailty.
Sorry, Dr. Sangeeta, the sound just disappeared.
I wanted to know more whether there.
So the tool that you use is, what's the name of it again? Fright, did you say, or?
Fried phenotype, they said.
Fright phenotype. Do others in the Indian group or use it? I'm not familiar with it. Rachel, maybe you are?
No, I mean, I think I came across lots of different assessment scales.
Thank you.
Yeah.
Priyanshu, would you like to talk about that?
Hello, everyone. Yeah, so Fried's phenotype model is a newly introduced frailty scale that we use. Initially, we were using clinical frailty scale, which is also a type that has many domains. It's like multi-dimensional scale which we use. So Fried's phenotype model basically consists of 5 categories, as Dr. Sangeeta has already explained. And those 5 domains in that we come across. So after assessing that, the scores between 0 to 1 is not frail, and 1 to 2 is pre-frailty, is addressed as pre-frailty, and above 3 is the one we address as frailty. So that's all I know about. I think Sangeeta ma'am has already explained about what are the domains and how do we assess that. So the other scale I'm aware about is the clinical frailty scale, which has some 9 domains. That and then so it includes very fit, well symptoms, managing well, vulnerable, terminally ill, severely frail, and then very frail patients. So that is one I'm aware of, and the other one is that Fried's phenotype model. Thank you.
Thank you. And do you find these helpful in your clinical practice?
I'm sorry, ma'am, I have not used either of them any time recently.
Sure.
But these are the two models and the scales I have come across for addressing and assessing the frail patients.
Yeah,
I have not used in my setup.
No, that's very, very helpful. Thank you, Priyanshu.
Thank you.
Because I think there is always a not difficulty, but a challenge to incorporate clinical tools into our clinical practice, and I wonder what others' experience is. Because also, Rachel, you were talking about if we could refer early in the frailty trajectory to palliative care, and so that often then you think, well, how can we capture that sense of what is early? And it's tempting to think that a tool might help with that, and yet sometimes we don't always need the tool to recognize. But do you want to comment on that, or other presenters comment on that? Oh, Priyanshu, sorry. Yeah, you're in.
I'm sorry, ma'am. I just wanted to add upon, there's one more model I'm aware of, which is called as Rockwood's accumulation of deficits model. I just know the name of this model, but I'm not aware of how the model is defined as. So it's called Rockwood's accumulation of deficits model. That is also for frailty that we use. Okay. Thank you.
Thank you. I think we need an Indian scale.
Odette, just to add to that, then I think in the literature there's a general consensus that if on whatever scale is being used, you have someone who is identified as being moderately to severely frail, then they're nearing end of, certainly severe, a nearing end of life, and the referral should have come a lot sooner. So I think if you if somebody is identified as being frail, or in the early stages of frailty, then that's the point at which a referral to palliative care could be made. And it doesn't mean they're not still receiving those curative interventions, and that over time the palliative care input will increase as it would with any patient with life-limiting illness.
Because did you say that once frailty is identified, even at that early stage, then prognosis is in the region of 6 months? Did I hear that? Or
so severe frailty,
severe only.
Yeah,
okay.
and moderate will be within 5 years is a 50% risk of death.
Okay.
Yeah.
Could I ask, am I missing any hands up before I, no. Can I ask Nisha, who's joined us from Australia, who's an advanced trainee in palliative medicine, if she would like to share some of her recent audit in falls in a palliative care setting? Nisha, would you be happy to comment?
Hi everyone, thank you Odette for the introduction. So as said, I'm a registrar here in palliative medicine, and I'm still towards my tail end of doing my manuscript write-up, waiting for a few results as well. But essentially Odette is one of my supervisors in this audit. So the audit is a retrospective study of 71 patients in the palliative care unit over a period of 1 year who sustained about 117 falls, out of which at least 28% of those falls were all from recurrent fallers. So the data that I actually collected was the demographics of the patients in the palliative care unit, just the nature of the falls, and also the risk factors of the falls. So those were some of my aims, as well as also assessing the adequacy of our riskman reporting system of where all the falls get recorded into by the staff. So essentially, it's still sort of in process, but what I've found so far is, at least from a demographic point of view, there was no real significant difference between the ones who fell single fallers and recurrent fallers. About 89% of patients had used opioids before falls. The lots of falls were roll out of beds, and there were 90% that were unwitnessed. There was a significant association between the mobility status and patients that had recurrent fallers. And I'm talking about patients who were either supervised or they were walking with walking aids. just as Rachel said, the tool that we use is the FRET tool. Most of the patients that had fallen either showed that they were either low or moderate risk of falls, which sort of makes us think whether the tool is appropriate in the palliative care unit. I guess what I'm still sort of writing up, but a few things that I've looked at is just the relationship between the mobility status and the patient that falls, and whether we need to look harder in terms of what would be the best appropriate tool to use to assess the risk of falling in this cohort of patients, and also better defining falls and whether rollouts, which is quite prevalent in this cohort, and whether they need to be included in the definition of falls as well. Yeah.
Wonderful. Thanks, Nisha. I must admit your audit made me much more aware of just how common falls are in a palliative care setting. I hadn't appreciated that.
Thank you.
It's really worthwhile. Any other comments or questions? And Priyanshu, thank you for writing all those scales there. I guess the message is there are many, but they may not all be appropriate to a palliative care setting, or palliative care is a very wide group of patients, palliative patients. Some are still quite mobile and some are completely bedbound. So there may be different scales that are more appropriate to different populations of palliative care patients, but perhaps it's also a question of becoming familiar with one or two scales and then seeing how you can make use of them in your setting. So shall we move on to the first presentation then by the team from Vizag? I think Priyanshu, you're presenting that. Over to you.
So should we start with the presentation, ma'am?
I think so. Yes, please.
So yeah, I would share the screen then.
And if you have any other thoughts about this topic, please feel free to add them to the chat. We can always come back to that after the presentations and keep the discussion going. Thanks, Priyanshu. Can you share?
I'm sorry, I'm just taking a minute. I'm not.
That's all right. No, that's all right. Take your time. It's no rush.
If you're not able to, let me know. I can share it from my end.
Yes, ma'am. Thank you. So I have to start. Sure. Okay, is my screen visible to everyone?
Yes, it is. Can you make it into the presentation view?
How do I do that, ma'am?
It is in presentation view. It is in the presentation view, but we can see all the slides together. So you can see a marking like 70% at the end of the slide, right end. I think that doesn't work in your presentation. So can I share it from my end if it is a possibility?
Yes, I think that will be convenient for us.
Okay, perfect.
Wait, let me just try once, ma'am.
Sure.
There has been a little changes in the slides. We have shared it to you, so.
Okay. You can try once again.
Stop share. With the presentation, ma'am. Okay. So I am Priyanshu and this is Alisha, our clinical psychologist, and I'm the physiotherapist here at Homi Baba Cancer Hospital and Research Center from Vizag. So I'm presenting a case of 81-year-old female who was diagnosed with non-keratinizing squamous cell carcinoma of lower two-third esophagus, grade 2 invasive breast carcinoma of no special type. Her ER was negative, PR negative, HER2 positive with grade 3.
Sorry, Priyanshu, the slide hasn't moved on. Can you go to the second slide? Are you talking about the second slide at the moment? Okay, here we are. Thank you.
I'm sorry, ma'am.
Maybe it was just my computer might have frozen. Can everybody see the second slide?
Now we can see it.
Okay.
Zoom a little more lower. Yes. Now we can see it.
Beautiful. Okay.
Okay, so I shall start once again.
It's
So,
all right.
am I audible now? And the slide
Yes.
is visible?
All good.
I'm presenting a case of 81-year-old female who was diagnosed with a non-keratinizing squamous cell carcinoma of lower two-third esophagus, invasive breast carcinoma of no special type, grade 2. Her ER was negative, PR negative, HER2 positive with grade 3. Metastatic liver lesion cytology showed metastatic poorly differentiated carcinoma. Her presenting complaints in the medical oncology OPD was difficulty in swallowing solids since 10 days, tiredness and restricted mobility. She needed a walker to walk around the house. So her history of illness included dysphagia to solids since 10 days, feeling of incomplete evacuation since a week, nocturia, and MMRC grade 2 breathlessness. Fatigue on NRS showed 7 on 10, and with palliative performance score, her score was 60%. That is, ambulation was reduced, unable to do much of housework due to the disease, and occasional assistance was required and reduced intake.
In the psychosocial aspect, if we see that the patient has 2 sons and 4 daughters, all are married and settled. Now, younger son is a private employee. The elder son is retired. Now, eldest son take care of her. Primary caregiver, eldest son and daughter-in-law. Patient does not get along with daughter-in-law, that's what she said. But then again, she accepts that they are good people, that's in quote unquote. Regarding the family independent, now son quotes that mother-in-law and daughter-in-law issues. That's how he quotes it. Financially stable, adequate support, and she loves cooking.
So this patient, that was the psychosocial aspect. And when we come to her evaluation and plan, so she was pre-evaluated with carcinoma esophagus at a local hospital. She came to our hospital and then again was further evaluated on 5th of January. We advised a CT thorax and on an upper abdomen. So in the Joint Clinic 1, which was decided to plan the further management, was done on 11th of January. That suggested a mammogram and biopsy of right breast lesion and FNAC of liver lesion. Further, to have a discussion with the family members and to explain the prognosis and treatment options for a shared decision making, we had a Joint Clinic 2 on 24th of January again. So these are the examination and the investigation we did and the findings we had. So CT scan of upper thorax and abdomen showed 6 centimeter long esophageal lesion from the level of inferior pulmonary vein. There was no mediastinal lesion and 2 liver lesions of respectively centimeters. The biopsy of breast lesion showed invasive breast cancer of no special type, grade 2, and FNAC from liver showed poorly differentiated carcinoma. So her intent of treatment that was further decided in the Joint Clinic was palliative. Further disease-directed therapy, she received EBRT, radiation therapy, 5 fractions to esophageal primary for 1 week. And oral chemotherapy was capecitabine and lapatinib at 50% doses. So we started further with the symptom management and kept her on morphine 2.5 TID for breathlessness, ondansetron 8 mg for nausea and vomiting SOS, that was post-disease directed therapy. Then she was kept on metoclopramide 10 mg TID initially and then continue SOS. We also advised stimulant laxative with stool softener, that is syrup pimafin plus. So the psychosocial intervention, I'll pass it to Alisha. She'll explain further.
Now, when we talk about psychosocial intervention, at that point, we have done a supportive counseling for the patient and the caregiver. The first thing that we do is rapport building with the patient and the caregiver as well. And then is like venting it out, free association, which we call it, letting the patient speak. Then then questioning, use of questions. For example, picking up few sentences from what she has said and then questioning it. That gives a clarification to the patient itself. Like, what is she thinking about it? That's how we got to know that when she was talking about the daughter-in-law issue, she said that, no, it's not that much. It's okay. They are good people. So that is how you have to clarify using the questions. The third of all is the simple relaxation techniques that we advise, which is simple breathing exercises, just to calm them down, the inhale and the exhale. And the fifth one is the caregiver counsel for not affronting, because it was seen that sometimes due to small issues, there were fights going on. So it's better that we advise the caregiver and try to tell them that it is not required. We can pause for a moment and then take a step back and look at the situation, the other form of the other side of the scenario. So that's how we take the counsel the caregiver with the patient, affronting the patient.
Thank you. So when we see, okay, now we see the physical intervention. Okay. Yeah, so when if we see from physical intervention and physical aspect, so we started with the effective assessment. So firstly, what we saw was we started with the assessment of a functional status. So as to address and to plan further management or to prescribe the exercises. So functional status, we use the CARS ADL scale. Then for ADL, so we associated as to what she is able to do and what is her disability. Also assess for her gait patterns. What is her gait patterns? Does she require any gait mobility or a gait walking aid or anything? Then further, we also assessed for her for falls and also for her balance. What is the required, what is the fall risk, and how can we address the fall risk in this patient? Now, how we managed symptomatically was, for the gait training, she used a walker for mobilization. So that was, we continued with that and also included the caregiver in the plan and addressed her frailty as to how we will continue the gait training in that patient. Now, prevention of falls, we see the major domains and the major factors that can be responsible for her falls should be her stairs, if the bathroom is slippery, and her shifts and transfers. Now, we also advised her for the ADL modification, considering that she was going through an illness and also her age. Management of breathlessness, we advised for non-pharmacological management that included breathing technique, pursed lip breathing, pacing of activities. Also, we also asked, continued, so the other factor that we associated with the pharmacological aspect was usage of stimulant laxative, because to avoid any further exacerbation or any exacerbation if she is passing motion, if the stool is hard. Management of fatigue, yes. So for this, we asked the patient to prioritize the activities. So in a day, and we included the caregiver also in this. So in a day, in the whole day, if the patient finds it difficult to perform for certain activities, or the fatigue rate is more in the evening or in the morning. Suppose the patient is having a less amount of fatigue or is not very tired in the afternoon. So we ask the patient to do much of the activities during that time when the patient is not tired much. So prioritizing activities, we educated the patient and the caregiver. We advise the patient to pace the activities and further changes in the quality of life. For maintaining muscle strength, we advise for mild range of motion exercises and walking, and provision of orthotics and braces if necessary, that was kept for anticipatory, although she was already walking with the frame in and around the house. So in this patient, her major concern was dysphagia to solids, fatigue, weakness, change in the quality of life due to the disease, dependency, if we see from our side of view, because this patient, she was quite independent before this episode of illness, and family support according to her. So this, according to her, she questioned this. Now, the other major concern was fall risk and the suspect of having a knee pain that was suspected because of the osteoarthritis in the bilateral knee. So if to summarize how we manage this patient comprehensively, the comprehensive care of plan included physical, psychological, practical, anticipatory, and decision making. So if we see from physical point of view, her symptom was adequately controlled and with the medications and with the regular review. So we continued the same by preserving functionality to the maximum possible extent. Psychological aspect.
In psychological aspect, the first is the acceptance from the family and the patient. Acceptance from the family and the patient. So whatever the procedure and the diagnosis and the prognosis that is going on, that should be acceptable by the family and the patient as well. We have to make our point very clear. Second of all is to fulfill information needs. Whatever is required, the entire procedure, what are if the patient is going through chemo or anything of that sort, the process should be very clear. The information should be provided to the patient. That will give them a clear idea about the picture. The third is the supportive psychotherapy that involves the caregiver and the patient as well.
Again, if we see from practical side of view, so we managed breathlessness, fatigue, and knee pain. That was due to the suspected arthritis non-pharmacologically. Anticipatory, we kept her on anticipatory medication that included dexamethasone. And further, we also gave her feeding options for further future plan. And place of care, her place of care was at home, discussed with the family and patient. Now, further decision making, we included patient and family preferences. Now, advanced care planning was done for this patient as to what medication was to given to her in the anticipation, feeding options, and also the place of care. We also kept her on a home care setup that through continuity of our care by our ISCC team, that is integrated hospital based continuity of care team. Surrogate was elder son, who was her medical decision maker in the family for her. So to summarize, this is a comprehensive gold standard assessment format, which I got from Physiopedia. Okay. The assessment was a multifactorial assessment, which we did from our multidisciplinary team. Further, after that, we stratified the problem list. We listed the problem list, and according to that, we tried to identify the goals of care and bespoke the care of plan with the by discussing with the caregiver and the patient. Further, we planned the intervention, and then later we also kept on a regular planned review, including her home visit and also review to the OPD as and when with the symptoms. So I think discussion points we can probably discuss later. Ma'am.
Right, talk about this problems encountered.
Okay, so the problems encountered while intervening this patient was further, the first problem we encountered was as she was old, she refused to exercise regularly as she found it cumbersome. And then probably she did not practice the relaxation techniques also because advised by a psychologist. She quoted that she doesn't wish to do the exercise as she would miss her serial episode on television. So these were the problems we encountered, and how we overcame it was to associate her problems with the solution itself, because so what she loved cooking. So what we did was we encouraged her to walk, and for walking her pain had to reduce. She complained of knee pain. So we just had to tell her that if you have to walk around the house, and if you love cooking, if you would want to do the cooking and stand for longer, you should probably encourage yourself and the caregiver. We also advise the caregiver to encourage her to do the exercises so as she can move around the house and do the cooking if possible. Further, yes. So discussion points for this patient would be what more could have been done to provide a total care to the patient and to improve the quality of life of the patient. How do you think frailty was addressed in this patient? Okay, so that is it. Thank you.
Thank you very much. I believe Odette's internet has gone pretty patchy, and I think she's disappeared for the moment. That was fantastic. Thank you. Really comprehensive. I might suggest that we move on to the next case presentation before going through your discussion points. They're fantastic questions, but I think we might be able to tackle those in the breakout sessions, if that's all right. I'm just conscious of time. Sarah, do you want to?
Yep, that's fine.
Second presentation, we might need to make it snappy.
That's fine. So I'm Sarah. I'm a community palliative care nurse and I live in Melbourne. And together with Rachel and Joan, who is a nurse consultant in Sydney, we've created a case study and presentations today. So I'm just going to share that. I hope it works. Oh, hold on, share my screen. Sorry everybody, I'll just get it up. Please tell me if you can see it. Can you see my screen?
Yes, we can see your screen.
Right, so I'll just press present, hopefully. Okay, all right, so I'll get going because that's what we need to do. So this patient rings true to many patients that I see in the community in Melbourne, but this was one particular patient I had about a month ago. So this particular lady was an 88-year-old woman who had a metastatic non-small cell lung cancer and brain and bone metastases. And they were both diagnosed, sorry, I can't actually see I've got something blocking the date, but what have I written there? Can anyone see the date? Because mine's blocked, unfortunately. 2020.
2020.
Thank you. There's something in front of my dates. That's okay. So this patient was referred to us as a community palliative care patient, but I've included the referral information just for a little bit more depth. So this patient was brought to a hospital via an ambulance after a fall, and she was found dehydrated, hypotensive and delirious. She was rehydrated in ED and then taken to a medical ward and seen by the palliative care consult team. Her presenting symptoms were loss of appetite, dizziness on standing, intermittent loose bowels causing urge incontinence, and left leg pain on movement. The patient stated really clearly that she didn't want to return. She wanted to return home at all costs to see her cats. And she was very adamant that she didn't want to be admitted to an aged care facility. As is often the case in Australia, the family were all working full time. She had 3 very supportive adult children, but none could attend the hospital. So they all joined a family meeting via FaceTime. So as I said, this lady was diagnosed in 2020. She had multiple rounds of chemotherapy with a moderate response. In October 2021, she was admitted to hospital with an infected skin tear to her leg, treated with antibiotics, surgically washed. The wound was surgically washed out, and then she was sent home with community nurses. She was then diagnosed with bone metastases and not offered further chemotherapy because of her frail state and chronic wound and age. In November 2021, she was given radiotherapy to her left femur for pain management, and in December 2021 referred to community palliative care in Melbourne. Other past history of note was that she had a past history of hypertension, osteoarthritis to her knees, and you can see there her current medications. Probably the most of note given her history were the antihypertensives, the fentanyl patch 12 micrograms per hour, and her PRN Ordine. So just a bit of psychosocial background. She was a retired school principal. Her family describe her as the matriarch and fiercely independent. She's married and has an elderly husband who is very doting, 92 years old, still driving her to appointments and cooking, but also uses a wheelie frame himself. 3 adult children, as I said, working full time, 5 grandchildren. 1 granddaughter is able to visit in the mornings and no one can visit in the evenings. They have good support at home in terms of medicines delivered and groceries delivered, but they had previously refused all aged care assessments and community support. They have community nurses weekly to dress her wound, and community palliative care attend weekly. Previously, she was able to shower herself, but does not own any equipment in the home. So just examinations that might, or extra information that might be helpful. In ED, X-ray showed there were no fractures and her full septic screen was clear. She had bony metastases that are shown there, bloods that are shown there, and her current weight was 45 kilograms. And on examination, she was alert and orientated, an incredibly cachectic woman, chest clear, bowel sounds active, mouth very dry, and skin very dry. So yes, that's the clinic, that's the picture of this woman. So now what we're going to do as a team, Joan, Rachel and myself, we're going to give you 3 different perspectives from 3 different disciplines about interventions that would be, or that were appropriate for this patient. So we're going to start with Joan, and Joan is a nurse consultant at the Royal Prince Alfred Hospital in Sydney, and so I'll invite Joan to unmute herself if she can.
Can you hear me?
Yes.
Oh, good.
Can you still see the screen?
I can see the screen beautifully. Thank you. Because of the time factor, and thank you for that, Rachel, and thank you, Sarah, and welcome everyone. And I realise it's getting, time's getting on. And what I thought I might do is just pick out some really pertinent practice points to start my presentation with instead of end with, so that if we do run out of time, I feel like I've got some of the points through that I really needed. So when we're talking about frailty, my go-to point is frailty is really what the patient tells us it is. And we can use charts, we can use checklists, we could use lots of other things and tools to help us in that assessment. But I think sometimes the word of the patient gives us the strongest message. What is frailty for you? It's, I feel uncomfortable, I can't explain it. I feel tired all the time, even after a big sleep. I feel my muscles don't work. I feel like I'm getting worse. So all of these things really paint a picture, and this information can be gathered, especially by nurses and allied health, while we're actually attending to the patient. It's something we can observe, we can ask about, and we can speak about by listening and observing what the patient says. So practice point is, for me, a really strong one is, I often ask the question, what does this frailty, this feeling, stop you from doing? What does that stop you from doing in your daily life? Or a question of a similar nature of, you know, what is bearable for you and what is not bearable for you? Because each individual person is going to answer that differently and feel that differently. Some people can put up with a lot more than others. It's an individual response. But what does it stop you doing? But also, what joy does it give you? And in that recent presentation, you found the joy of that person, that lady's cooking. And that allowed you and gave you the information necessary to provide a plan that was individualized for her. So listening is a really important thing. And also just being able to spend some time with the patient, because we do know, and Rachel's already covered it, but frailty is under-recognized, under-reported, and under-treated because frailty is an expectation of illness often and of getting older. And while that is a really pertinent point of view, I think sometimes I know people are really undervalued in what they can do and what they want to do and some goals that they can set for. So it's really important. What does it stop you doing? What do you enjoy doing? And also, how long has this been with you? What were you like last week, last month, last year? What's been the time frame for some of this change in that frailty, which gives us information also about how that person is progressing. The next slide is really, I can't press it on, can I? Great. So this is a slide which it sort of recognizes that, yes, frailty can be anticipated, but it's often that silent, unpredictable symptom. And I think, and I see this in Australia a lot, and I see this when I visit India, often it's influenced very strongly by the culture, cultural influences, definitely by language, by words we use, by words we choose to use, and also from the spiritual dimensions. But when I look at that photo and I see Dr. Rajgopal listening to that patient, and I see an Australian man sitting in the chair, there's not much difference between them. Universally, we see the same patient. That same patient presents to us. And I think the cultural context around it is often what is the biggest challenge in being able to get some of that care and that support that people need. Next one. So I'm going to run out of time, I know it already, but what I would like to really stress is this is a comprehensive whole person-based assessment. It looks not only at the disease and the trajectory of the disease and how that may unfold, it also looks at the person underneath it. And that's what communication is all about. So when I'm looking at my patients and I'm meeting them for the first time, or I'm getting the patient ready to go home, I move through those different sections, and I've given it the CARE model, C-A-R-E, and this is available to you at the end of the session. So I'll go to the first one that I'm going to talk a little bit about. Thank you. And we're talking here, care. What do I want to talk about when I'm talking about that patient going home and being a frail patient? What I really would like to talk about with that family is that we have a clarity of goals of care, and they are documented, and then we have a consensus on that with the family, with the treating teams, and with the carers. And that's a really important thing. We know a lot of information about that patient. We know a lot of information about that disease trajectory, and we need to take that information into discussions with the family to lead them into a place where they feel comfortable about what's going on from the cultural and spiritual perspective as well. So yes, in respecting a patient's wish, it's a wonderful thing if we can do it. We can't always do it. But with this patient, there seems to be a whole group of people who can help support, which is not actually the same that we get in Australia. We have to buy a lot of that in. But I think what we're really trying to impress on the family is that what we're looking at are comfort measures. We're not looking at curative measures. We're not looking at unnecessary interventions that are not going to be of value for the patient. We are looking at measures that will provide the patient with the comfort and the dignity that we are approaching. And I'll just say one very important thing. It would be wrong of us not to mention the potential for that person, that patient, to die at home and what that might look like, especially when people often, feel that frailty is just completely downhill. There is changes in frailty that can respond to some of the treatment, and I think we shouldn't underestimate that. Next slide, please. And here we've got things that I think have been covered fairly well in some of the presentations that are following. And I think probably the one I would point out really very strongly there is the assessment and rationalisation of medications. What does this patient need? What does this patient not need? What can help influence that fatigue and lethargy? Do we need to think about the role of blood products in the future, or sometimes the use of steroids? Different things that are reversible. We're looking for reversibility. We're not looking for cure, but we are wanting reversibility where comfort can be ensured. And I think we'll go to the next slide really quickly. Thank you, Sarah. And that talks about the reversibility and the preventability. And some of that is pharmacological, but so much of it is born on good nursing care, really simple things that can happen at home very clearly. And I think that we're looking at educating the family and in being able to look after that patient in a way that is respectful to their wishes and is safe for that person at home. Next one, please, Sarah. And the evaluation. Can this care be provided realistically at home? Is this a safe environment for that person to go to? Bearing in mind that there's going to be changes in the level of dependency and care needs, and also the carer education. I mean, that is really going to be important. Integrating frailty into the palliative care part. When does that change? When do we stop, encouraging people to get out of bed? When do we see the subtle changes of a person who's dying as opposed to a person who is frail and getting frailer? So we want comprehension. And I love those two presentations because I've never seen such beautifully documented case studies. You don't often get all that information in patient notes, but look how easy it made us to talk about it, all the levels of information that were there. Comprehensive note-taking is vital. Documentation is vital in being able to look and provide a care plan that is comprehensive so we can hand over to Rachel in the
Joan.
therapy setting.
Now we're very, very thank you, Joan. That was I'm sorry, time is so short.
That's okay.
Now thank you, Joan. Now we've got Sarah and Rachel to talk about this patient from their perspective. Unfortunately, we're really running over time, and as I put in the chat, we won't have time for the breakouts, but we would like to have at least 10 minutes at the end of the case presentation for some reflection and discussion. So if you can try and, I think we've covered a lot of the material already in the previous parts of the discussion. Thanks, Rachel. Over to you.
Thanks, Joan. Thanks, Odette. All right, I'm going to fly through this. I think a lot of it has already been covered by the physiotherapy discussion in the previous case anyway. So Sarah, can you move on to the next slide already? Skip that one. Just really briefly, we mentioned, oh no, go back. Sorry.
It's all right, there's time.
Perfect. We mentioned earlier the falls risk assessment, or the FRAT as we call it here. So this just shows you a common FRAT that we use in Victoria. I think this one's been put out by the Department of Health in Victoria, where you number off the risks according to the risk factor status and the risk factor checklist. But we can circulate that if it would be of benefit to any of you. Next slide, please, Sarah. So what I think the main point that I really want to get across from a physiotherapy perspective in considering this particular patient is firstly the need to balance her safety and her current mobility with what her actual goals and her family's goals are, and what she wants her quality of life to look like. So sometimes I think we can try and prevent falls so much that we sometimes might risk not listening to the patient themselves. So, you know, what does this lady want from her time in hospital? What does she want for herself in going home? How does she wish to maintain her independence, and how can we best support her to do that? Of course, we want to minimise the risk of falling and minimise the risk of injury, but we know that we can't entirely eliminate her risk of falling. Towards the end of life, I think sometimes it can be appropriate to accept the risk associated with attempts to maintain her mobility and her independence where it promotes her dignity and her quality of life. But also to accept that there may be some patients who don't wish to be mobile, and we need to accept and understand that as well. So I think that's the key thing from a physio perspective. I think sometimes we can come in and say, right, you need to stay in bed because you're not safe enough to be walking around. But that may not be where the patient is at and what that patient wants. And so we need to really work with the patient and understand that. The second area to consider is the role of equipment, which we've heard from the previous case team on their case study about in terms of gait aids, comfortable chairs to sit in, that kind of thing, and exercise. So exercise, balance and functional exercises have been shown to effectively reduce risk of falls and improve quality of life for people with frailty and older people, in particular with older people, with some evidence on the benefits for people living with cancer. I think it's really important to note that walking programs alone will not reduce a person's risk of falls. They will help, and of course maintaining mobility and not not sitting around and having muscle wasting and all of that kind of thing is important, but balance exercises will do more for a person in terms of reducing the risk of falls than a walking program alone. And then the final thing to consider is working with the multidisciplinary team for discharge planning. And Sarah's going to talk about a few things that a physiotherapist would consider in conjunction with a nurse. So you can skip over my next two slides, Sarah, and we can share the slides later.
Okay, very good. Thank you very much, Rachel. So yes, I'm going to talk about considerations from a community palliative care nurse's perspective. So if I was seeing this patient, the things in a home visit for about an hour, the things that I would focus on are the home environment, doing a medication review, figuring out what she needs and what she doesn't need, what's increasing her falls risk, very basic pressure area prevention, because these patients are very very susceptible to getting a pressure area at home, and prevention is the most important thing in regards to that. And then doing a really great patient and carer symptom management plan, which I'm going to show you what I would do. So what I wanted to show you is this is what when I do a home visit in Australia, this is what I would call a typical home. And if you have a look there are this is not an unusual home, and there are so many things in that picture that show big falls risk to me. There's lots of clutter everywhere. There's rugs, there's low chairs, there's ropes, there's cables, there's nowhere to put the medications. And when I go into a home like this, one of my nursing interventions is to sit down with them and talk about how to improve some of the things that may trip them or may cause them to fall. And because there's a lot of them, and I put them all on this slide, and we don't have time to talk through them all, but I put in italics, I put the most important ones from my perspective, which are clutter. Is there clutter in the walkways? Like if you look at that picture, there's no way a frame could get through there. You know, talking to them about making room for the frame. The other thing I think is really important is, just as Nisha said, that falls often happen at night, and often the patients are trying to get to the toilet or bathroom in the evenings. And I think having a conversation with them about their evening setup, do they have everything that they need on their bedside table, including medications, a call bell, a mobile phone? Do they need a commode next to their bed? Or do they need a incontinence pad for the evenings to make them safer? These are all things that I do in my nursing visits with these patients. The next most important thing is pressure area prevention. And every patient that I see in a home visit, I speak to them about basic pressure area care. And these are even mobile patients. And I'll just talk to them about the fact that even when they're sitting more than they would have normally, that they're at risk of pressure areas. And I teach the carers in particular to check the patient's sacrums, heels, and other bony prominences for reddened areas. I encourage them to move. And if they do have a stage 1 pressure area, then we can get them a pressure area relieving device in Australia. The other thing that I think is really important, and Nisha also touched on this, as a nurse in a community setting in Australia, definitely part of our role is to review the medications that the patient is taking. And there are studies that show that patients who are on more than 4 medications have an increased risk of falling. And the more medications are above that 4 medications, that level increases their risk further. And for this patient, this case study, the things that I would be doing, the 2 medications I really want to talk about that I would have reviewed, which were antihypertensives, and as a nurse doing a sitting and then a standing blood pressure. And if there's a postural drop, asking, gently prompting the GP or the palliative care physician to review that is a really important role we play as nurses, to be part of that review. And we've got pharmacists who are listening today, so they're very much part of that too. The other thing that's really important to consider are the opioids that the patient is on. And for this particular patient, she was on PRN Ordine. So I would be talking to this patient about when she takes it, and asking her to make sure that she's sitting when she takes it, or maybe just before she goes to bed when she's in bed. They're the interventions that I would be doing as a nurse. And lucky last, this to me is probably the most important part of my role as a community palliative care nurse, is to create with the families patient and carer symptom management plans that go through step by step what they need to do when symptoms arise at home. Because ultimately their symptoms will have a challenge at home. They will become short of breath, or they will have pain. And if you can outline what they need to do in a really clear and simple way, then they've got a chance of staying at home and doing achieving their goal. So I've given you examples of this is my handwriting, so excuse me, but every time I go into a patient's home, I'll do a plan like this. So for this patient, I would have done a pain plan, and I've told her what to do outlined what to do in the every day, which is check your fentanyl patch, take your regular paracetamol. But if pain is escalating, then these are the steps you need to take. And probably another important part for this patient is an evening safety plan. And that includes things like, what do you need to do before you go to bed to make sure you're safe? What are you going to do when you want to get up? So those are the interventions that I would have done for this patient as a community palliative care nurse. So that is as an Australian team, that is the end of our presentations. And we probably don't even really need to sum up, but really this slide here is just saying that frailty is a syndrome that's characterized by physiological and functional deterioration, and it makes our patients very vulnerable. And as we tried to demonstrate, and our Indian colleagues did today too, the approach needs to be very multidisciplinary. So thank you for listening. And we do have discussion points, but Odette, do we have time for that?
Thank you, Sarah. Thank you, Joan and Rachel. And thank you to the VISAG team also. And apologies for all the disruptions with internet and also for not having enough time for discussion, which is really important in these sessions. But we've been presented with a wealth of information, and I guess just shows how a condition such as falls or frailty really is so much more comprehensive than perhaps we might first think it to be. I think we have perhaps 2 minutes for discussion. So I'd love it if people would raise their hands and just ask for any sort of clarification from any of the presenters, or we can probably stop sharing the slide in the last moment or two, and then we'll just need to wind up with a couple of final comments. Anil, you've been far too quiet today. I can pick on you. Do you have any comments you'd like to make?
I think, thanks, Odette. For me, the take-home points from today was from the Indian presenters. I love the fact that it was a multidisciplinary presentation, including the input from the psychologist. So just the ability to listen to the patient, because sometimes actually we can't fix things, but all we can do is actually hear their concerns, and the ability for them to vent or just say all of the things that are happening, the mother-in-law, the daughter-in-law problems. It sounds like that both the patient but also the son was able to talk about that. And then from the Australian presenters, very much the value, like Sarah showed, sometimes a piece of paper with just something very, very clearly written of the key points is absolutely essential, because people they struggle to remember what we say.
Great points, Anil, thank you. Any other thoughts or comments or questions? Good to see you, Dr. Vidya. Thank you for organising the presentation from your team.
Thank you, Odette. Thank you so much for the opportunity. You actually made us think more about frailty, because we see it so regularly that we actually dismiss it. But now, thanks to this, I'm sure the team also will start taking frailty more seriously. I'm hoping that that happens with this. And the Australian presentation, thank you so much.
Thank you, Vidya.
Can I add a comment?
Yes, please.
I remember I had 2 Indian nurses visit me a couple of years ago, and I took them up to our my hospital, Royal Prince Alfred, and I was showing them around the ward, and there was a beautiful board with all the falls risks and the socks that you wear, and it looked beautiful. It looked like Christmas. It was so beautifully decorated. And I noticed that the girls didn't take much notice of it, which I thought, oh my gosh. And when I discussed it with them, they just laughed and said, well, we don't have many falls in India because our patients are very rarely on their own, even in hospital and at home. So it's not as big a problem. And they, explained how just having that human presence made an enormous amount of difference in how people, dealt with their frailty and dealt with their, that feeling of demoralization, I guess, that they can't do everything they used to do. And I think within that is a lot of loss. And it's not just loss of death, it's loss of health and family and status, and it's a lot of losses happening all at once. So I think in recognizing that, it's really important, the power of a human being next to you. I just wanted to add that.
Thanks, Joan.
I don't know if any of the Indian nurses are on board tonight, but
thank you, Joan.
Can I just add?
Yeah.
So can I add something to that as well, Joan? I think that's a fascinating point, and I think we sometimes forget on our hospital wards that the scenario that's happening on the ward is not what's going to be happening at home, and that we can, as I said before, we can do everything within our power, like non-slip socks and alarm mats and putting the bed down low and putting a bedside commode in, all of those things for a patient who may be sitting alone on a ward. But what actually happens when they go home is a completely different picture. Sometimes they will be with somebody, and so their risk of falling is significantly reduced anyway when they're at home in their home environment. Sometimes it's being in a different place on a ward that causes them to fall because it's new and it's different. So yeah, I think it's a really interesting point about having human presence, and that sometimes they don't have that on the ward but may have that at home in our context.
And the nurses even explained that often that someone slept with the person. They weren't alone even in the bed. Someone actually physically slept there with them.
And I think we noticed an increase in the falls in the inpatient units during COVID, when there were so fewer family members staying with the patients in their rooms. Dr. Shilpa, did you want to comment? Thanks.
Yes. Thank you. Hi. So good to be here and attending this wonderful presentation. Thank you for giving me this lens of frailty and falls, just like shared by another Indian team earlier, that we see these risk factors right in front of us, and we often neglect it and they go invisible. That's a very important point that was being made earlier, that Indian patients are often not alone. That prevents them quite a lot. But I would like to add to that is that even though we have human support, we lack the infrastructural support. Like our houses are not built that way, especially in the villages. Like we have door thresholds like that, so people are at very high risk of falling. And another thing is that some people are too independent and they won't, even if they are not able to manage themselves, they'll be very hesitant and reluctant to call for help. So those are the 2 points that I wanted to add. Thanks.
Yeah, thank you. Yeah. And I saw Sarita turning her camera on before, Joan, when you asked if any of the nurses were there from.
Oh, fantastic.
Catcher. There she is. Hi, Sarita.
Hi,
Sarita. Hi, John.
Hello.
Hi. Very happy to see you, John.
Beautiful to see you, Sarita. Lovely.
I knew I was taking a risk by drawing attention to that, but
I want to see you all the nurses are sitting here.
Got the catcher team. Hello, catcher team. Okay. Unfortunately, it is now after time, and we're very Pallium are very strict about keeping to time, aren't you, Raju? So we better wind up. And once again, and apologies once again for all the disruptions, and thank you for persevering with us. Now, we will be sharing a poll after this after this session, and I think in the next day or so, Raju will send that round asking for your input into future topics, because this is a continuous program and we want to make sure that we're talking about things that are of interest to you all. So please send us your thoughts. We will be sharing the recordings and the presentations from all the presenters. Please continue the discussion in the WhatsApp group, and if you come across any other useful information about falls and frailty assessments, that's a good place to share that with each other. And I thank you all once again for your attention and contributions, and look forward to our next session.